So, good evening and welcome to OrthoTV. And for further proceedings, I'll hand it over to our convener, Dr. Rahul Katta. Over to you, sir.
Yeah, thank you. Thank you, sir. So I welcome you all on behalf of Rajasthan Orthopaedic Surgeons Association. So every month we are conducting a master class in different topics of hand surgery. And as today is Hand Surgery Day, so we are joining hand with Indian Society for Surgery of the Hand. I welcome the President of Indian Society for Surgery of Hand, Dr. Ravi Kumar Mahajan, and Secretary Dr. Pankaj. So they are with us today for this master class. We have a galaxy of faculty from national level and from state level. So first of all, I would like to invite the ROSA President, Dr. Arun Vaishya, to start proceedings for today's webinar. Dr. Arun Vaishya, sir. I hope there is some technical glitch with him. So now I would like to invite Dr. Ravi Kumar Mahajan to welcome everyone and say few words about this webinar and Hand Surgery Day. Over to you, Ravi, sir.
Thank you, Dr. Rahul. So it's a real pleasure for me to be part of today's master class, and I must thank the Rajasthan Orthopaedic Association and the Jaipur Hand Surgery Society, and particularly Dr. Amit Vyas for inviting me for today's master class and having it specifically on a hand surgery day. And I was just very happy to learn that this has been going on for the last probably about 5 months, and this is the 5th master class. So I think this is great on the part of the Jaipur Hand Surgery Society people and the Rajasthan Orthopaedic Association carrying out such academic activities on regular basis. And here I would like to, say a few words about the Hand Surgery Day, which is the first time that this National Hand Surgery Day has been started. And as most of you must be knowing, that it was in 1973 that on 23rd August, the Indian Society of Surgery of Hand was registered in Mumbai. And that is our foundation day. And that is why, the Executive Council of the Indian Society of Surgery of Hand decided that we should celebrate this particular day as a hand surgery day. And this can be a great handle actually for us to create awareness about the hand surgery, not only amongst the public but also amongst the primary healthcare givers. So, which will be very useful in creating awareness about this particular specialty, so that the people can benefit, and a lot of disabilities which occur because of the hand surgeries, hand injuries, and other hand problems, they can be avoided. So now regarding the presidential theme which we had this year, so I must tell you that it was in 2019 when I took over. So one thing which was very close to my heart, that I wanted that the new people who come out, after getting their training, they must have some way of, being their hands being held, by their seniors. So in the first year, we had the presidential theme of holding hands. And in fact, a lot of work was done on this by our secretary, Dr. Pankaj Hire, making various, rules and regulations, then how we will go about it. But unfortunately, because of the corona, so this could not be carried out. But anyway, we do intend to carry on with that presidential theme of 2019. And 20, again, it was declared as a almost nil year, though we had a lot of academic activities in the form of webinars. But then this year, again, I was nudged by Pankaj again to, come out with another presidential theme. So I was thinking all the time, what will be the right thing to do. And then what came to my mind was that this IEC, that is information, education, and communication. And this we thought we will put it for the prevention of disability following hand injury. So again, because of the corona in the first half of the year, so nothing much could be done. But then this hand surgery day, has really come handy, and we have, started working on this theme of the IEC. And this is just the start today on the hand surgery day. And we intend to work in the remaining few months of this year also. And later, of course, with this theme of the information, education, and communication. And I am sure that all of you know that now on this particular day, a lot of activities have been going on all over the country. If some of you are on the ISSH Friends group, you will realize that almost in all the institutions and the various hand surgeons in practice, so they are doing various symposia, seminars, webinars, and a lot of other activities, with the press and all, and creating awareness about the hand surgery, and particularly about how to avoid the disability following hand injury. So this is just a start, and I must give a lot of credit to Pankaj again, for doing a lot of work in this direction and involving almost all people all over the country. He divided it into various zones and put various, lead people who talk to, other hand surgeons in their region, and then, this activity is going on. And I'm so happy that you people have also decided to have this particular webinar on this particular day. So with these words, I would, give my best wishes to all of you on this the very first hand surgery day, which is being celebrated nationally, and also wish very best for today's masterclass. Thank you so much.
Thank you so much, Dr. Ravi Mahajan, sir. Today we have Dr. Pankaj Hire, Secretary of Indian Society for Surgery of Hand, with us on this day of Hand Surgery Day. So I would like to invite him for his kind words. Dr. Pankaj, over to you.
Thank you, Dr. Rahul, and it's an honor for me to talk to members of ROSA and Jaipur Hand Society and all the listeners. I will not stand between you and the academic fees that awaits you, but it's my duty as a secretary of ISSH to share the idea of Hand Surgery Day with you. And I talk to you as a representative of ISSH. As Dr. Ravi Mahajan just told you, ISSH was founded on 23rd August 1973, my birth year, and hence we are celebrating Hand Surgery Day on this very day. But why do we need to celebrate Hand Surgery Day? Well, the simple answer to that is we need to make a difference in outcome of hand injuries. And how do you do that? Do we refer all of them to hand surgeons? Certainly not. That's not how it's going to work. The 80-20 rule applies here too. 80% of all hand injuries can still be managed well by non-specialist hand surgeons, largely because of their training in orthopedic surgery, general surgery, and plastic surgery. It's the remaining 20% who might need attention of a specialist. But for the 80%, it's very important that whoever is dealing with these injuries do it right the first time. The dictum in hand injury is if you have not done it right the first time, the subsequent surgeries and subsequent treatment will always leave behind some disability and deformity, which was clearly avoidable if the primary physician did it right the first time. Remaining 20% might have to be referred to a specialist center, largely because it requires a highly equipment-based intervention like microsurgery, or it requires a multidisciplinary approach, and all specialists may not be available in smaller centers. How do we decide which 20% to refer? And this nice handout prepared by Dr. Ajit Tiwari highlights these red flags in hand surgery. And I will request Ajit to share this with all the audience through some means so that they can use it in their practice. And for some reason, if you just cannot refer, then there are 3 simple steps that ISSS urges you to follow. It is decontamination, splinting, and prevention of edema. If we did this well for every primary treatment of hand injury, we would have done a great deal of justice to hand surgery. And in the end, the hidden agenda behind the hand surgery day is reaching the unreached. Expecting every hand injury patient to seek a specialist treatment is not the right way to go. Expecting the patient to come and demand a certain level of treatment is not the right way to go. Important thing is we need to take hand surgery to the masses. We need to take a diligent hand surgery care to the doorstep of the patient. And that's the underlying purpose and hidden agenda of hand surgery day. And I thank each one of you, because knowingly or unknowingly, all of you will be contributing to this goal today. Thank you very much. I offer you greetings of hand surgery day and wish you happy learning.
Thank you, Dr. Pankaj. So the hand surgery, as you rightly mentioned, is very important, and the primary care is still very important, and it should reach to the doorstep of at the doorstep of the patients. So the masses of the orthopedic surgeons practicing in periphery must learn the basic facts about the hand surgery management, hand surgery cases management perfectly, whether they want to treat it primarily or they have to refer it. So not taking much of the time, now I'd like to hand over to Dr. Amit Vyas, who will introduce today's faculty members and then start the proceedings of today's webinar. Over to you, Amit.
Yes, sir. So, as per Executive Committee of ISSH, it was decided to make the primary care to more having instinct about the injury pattern. So we chosen this perilunate injury today for discussion. So the primary givers are the orthopedic surgeons, and beginners even can miss these injuries. So we chosen this subject for discussion, and I have invited our guest faculty, Professor Anil Bhatt. He is well-known academician in the country, and he's working at KMC Manipal as a unit of head of the unit of the hand surgery, and formerly he was the HOD of the orthopedic department. And his work in the field of hand surgery is well known in the country. And the second speaker is Dr. Ajit Tiwari. He's a good friend of mine, and he's working at Kanpur, and he's well-trained, fellowship-trained hand surgeon, and a great academician. And his main work about the wrist surgery is brachial plexus surgery. So, and then our galaxy of a star, my teacher and mentor, Professor Purnima Patni Madam, and Dr. C.S. Chaturvedi sir, Dr. Narendra Saini sir, Dr. Rajeev Siwach sir. He is working at Saraswati Hospital at Jaipur. So without wasting too much time, I would invite Professor Anil Bhatt for to deliver a master class on perilunate injury, so everyone will be aware about the injury pattern. Then it will be followed by the case discussion. Thank you, sir.
Thank you, Dr. Amit. Thanks again to ROSA and also the Jaipur Hand Surgeons Association. It's always a privilege, and it's almost like coming back home every time I come to your webinars. Thank you all the office bearers and all the faculty also for this opportunity. I'll just share my screen. Is my screen visible?
Yes, yes, sir, it is visible.
Yeah. So again, happy hand surgery day to all of you. Now, carpal instability is one kind of a topic which, at least as a postgraduate, I used to hate a lot and always had difficulty in understanding this. But the more I read about it, it's a very fascinating subject. So the carpal bones itself are all linked together. They're all like pearls, and they're all linked together with ligaments. The thread is basically the ligaments attaching to each of these. And once they start getting damaged, the instability sets in, and the entire carpus collapses almost like a broken string of pearls. So this is what happens with carpal instability. And that is the basic idea of this talk. I'll just go case by case so that the concepts can be understood. So you have a young male coming usually after 2 months with a history of fall, and he has a radial sided pain. These are his first x-rays taken at a local hospital. He was told that everything looks fine, and then he was put on some analgesics and sent back. And usually this is a presentation where they come usually after about a couple of months later. And the pathology is often missed because of the complex anatomy. So if people are not familiar with this anatomy, obviously the injuries would be missed. So the possibilities in a radial sided pain when somebody comes, obviously the most common would be a distal radius related injury. Scaphoid fracture sometimes is missed. That is the second most common. And the third most common would be a scapholunate injury, especially on radial side. And this is the first step in carpal instability. So one of the common injuries very often missed. So a very good clinical examination is very, very important for us to know where this injury happens. And as I said, the scapholunate injury is the most common missed carpal instability pattern. So to understand this anatomy and not to miss them, you should know how the normal wrist x-rays look. That's very, very important for practicing surgeons. And the standard x-rays for the wrist are PA, lateral and oblique. It's not the AP view, it's a PA, lateral and oblique. And why I say it is standard, because if you look at, compare the AP and the PA, you see the AP looks more jumbled up here, the carpal bones, compared to a PA, which is nicely and neatly arranged. So this is the anatomical view of the carpus. So PA view is the common, it's the standard view. And why do you say it is PA view? It is the most important thing. The ulnar styloid should be arising at the ulnar-most corner. If you look at the previous X-ray here, the AP, you'll see that the ulnar styloid is somewhere in the middle here. So this is the first step. The second is, of course, the axis itself. So if you look at the third metacarpal, capitate and radius, they all should be collinear. That's what we call it, collinear or parallel to each other. Third important thing is to see the smooth arrangement of the carpus itself. If you draw these lines along their smooth borders, they should be concentric like this, and there should be no break in this. So these are called as the Gillila's arcs. So this is what is required in these patients. If you look at the lateral view, again, the same axis between the third metacarpal, capitate and radius, they all need to be in single line or at least collinear to each other. And then if you draw this angle, especially between the scaphoid and the lunate, it's a very important angle we see a lot of times. We don't really have to draw. Just by looking at it, we can make out that it's almost normal between 30 to 60 degrees. And anything increase or decrease means there's a problem there. Now, also the other part is to know the normal shapes of the bones itself. We know scaphoid is very like a twisted bone, and almost like a cashew nut there. But the lunate is like a trapezoid kind of a shape. And if you look at this X-ray now, you see that that lunate is almost triangular in shape. When you see a lunate which is triangular shape, means it is tilted either dorsally or olarly. One of the reasons why that lunate is looking very different. So the same man who initially I told the first case, this was the first X-rays. Ideally, the X-ray should have been a PA view. And if the X-rays are normal, then you should start wondering why, what is wrong with this patient. And if you look at the lateral, you see this lunate is dorsally tilted. It's not sitting neutral like this, but it is dorsally tilted. And the angle has increased now, the scapholunate. So we know that there's a problem there. The lunate is moving somewhere. So maybe there's a problem in between the scaphoid and the lunate. So that is what is the interpretation should be. And anybody can walk in like this with a major gap like this if they have a scapholunate instability. And anybody can pick it up that there's a problem there. It's called as a Terry Thomas sign. It's a static instability. But the most important thing is to pick up the dynamic instability, or we need to image further for us to diagnose these scapholunate pathologies. So we do what is called a stress fuse. So if The X-rays look normal. The standard X-rays ask for a stress view always. And the stress view should be done like this. Is a clenched grip use. Both hands, patient is holding a pen or a pencil, and then patient has to be grip this, and both PA and AP has to be taken. The radiologist should know how to take it. And there you might see this difference. When the patient is gripping, you might see this gap coming here. Here, the capitate is trying to push this between these two bones. And I'll show you that in the C-arm image. Actually, this is a patient who had dynamic instability there. And when I'm stressing it, you see the gap appearing. The capitate is pushing it there, and the gap appears. So this is a dynamic instability. And this is the first process where the carpal instability itself starts. So this should not be missed. So when there is a gap here between the scaphoid and the lunate because of the ligament injury, or even if there's a scaphoid fracture, both the times the lunate now is detached from the scaphoid and it starts moving on its own, and it's still attached to the triquetrum. So if you look at the normal wrist movements, when the normal wrist moves from radial to ulnar side like this, you will start seeing this lunate extends when it's ulnar deviated like this, and it starts flexing when the radial deviation happens. So the scaphoid has that normal tendency to flex, and the triquetrum has a normal tendency to extend. And the lunate actually goes with the stronger bone. Wherever there is a link is detached, it starts going with the other bone. I'll explain that with the cadaveric thing. Now, this is a scapholunate ligament. It is detached here. There's a damage there. And now this lunate will now start moving with the triquetrum, which has a tendency to extend. That's why the lunate now goes dorsally and your scapholunate angle increases. And this is called as DC deformity, dorsal intercalated segmental instability. I'll come to that now. The lunate is now moving with the triquetrum, and that's why it's going dorsally. What happens if there is an opposite injury between the lunate and the triquetrum, the LT injury, lunato-triquetral? The scaphoid and the lunate now move together, and the scaphoid has a tendency to flex. So you see that the lunate is also flexed, and the angle decreases of the scapholunate. So this is called as the VC deformity, where the scapholunate angle becomes less than 30 degrees. So this DC and VC, we always hate these terms. As a postgraduate, at least I used to hate this term because I never understood what is this. But it's a very simple term. Dorsal or volar refers to the lunate, direction of the lunate, where the lunate takes. The intercalated segment means the proximal row bones. They're all intercalated, means they're all linked to each other by ligaments. The string of pearls, which I showed you initially, that's what it is. So dorsal intercalated segment instability means the lunate is going either dorsal or volar. And the problem is basically ligament damage. So they all involve the proximal row. So the carpal instability dissociative, you might come across this term, means there is a dissociation here between these proximal row. The lunate is the proximal intercalated segment, is the key bone. That's why I keep harping on the lunate. And that is the one which is the key for all these later problems where the lunate moves and how it moves. So this is what is called as the DC and VC deformity. So most of the time as orthopedic surgeons, general orthopedic surgeons also, we miss this during distal radius fractures. So always make sure you see this joint, the carpus, always see this patient has a distal radius fracture. But this patient also has this gap coming. So always make sure that we just don't fix the radius. We also have to look at one joint above, one joint below. One joint above is the wrist joint here. One joint below for me is at least the DRUJ here. So both have to be looked into and they have to be treated. So once you fix your distal radius, check for the carpus, the movements, and then you catch this lunate. You use a radiolunate wire like this. Make sure the lunate is kept in the neutral position. And then we pin this scapholunate joint. Acute injuries, just by pinning with the K wire is good enough. The ligament heals nicely. But the key is to keep the lunate in the neutral position. It should not be fixed in a dorsiflex kind of a position. So once you do that, you can remove the radiolunate wire. We also add one additional wire like this scaphocapitate wire, because the scaphoid has tendency to flex. So to keep it in that neutral position, you should add one more wire. So this is the correct way of fixing a scapholunate instability. One through this, one through this. But initially, the radiolunate wire is the most important wire for you to get the lunate into neutral position like that. So at the end of your surgery, once you fix your distal radius and you fix your scapholunate, all of them should move nicely like this. This is very, very important. So that dissociation should not happen between the scaphoid and the lunate, and they all should move as a single unit. That's very, very important. Now, if the force continues, So it didn't stop at that. This force continues. It starts damaging other ligaments, the capitolunate ligament, the lunatotriquetral ligament. And this is the Mayfield's theory of how this force progresses. And these were all studied in cadaveric studies. And another example I want to give, again, a high energy injury. If you look at the checklist, which I told you, the lunate is looking triangular here. The Gillila's arch is broken. So there is some problem here. And if you look at the lateral now, you see the axis of this third metacarpal capitate, it's fine. But the radius is somewhere lying in somewhere else. So they are not in the collinear fashion. The lunate is sitting nicely on the radius. But however, this is what is happening here, which means that the entire carpus is shifted back dorsally here around the lunate. So this is called as what is called as a lesser arc injury. Lesser arc means everything is happening through the ligaments. This force is going through the ligaments, damaging them. So this is leading to what's called as perilunate dislocation. Dislocation around the lunate. So that is what is the terminology, but it can go either dorsal or the most common is the dorsal. But remember, perilunate is not an isolated injury. It's a progressive carpal destabilization. It should start from scapholunate and then progress like this. And they're often missed almost up to 25%. That's a sad thing. And accurate interpretation of radiographs is the key to diagnosis. One more case I'll show you. Again, same thing, lunate looks triangular, but there's also fracture there of the scaphoid. And again, capitate is dorsal here, and lunate is sitting on the radius. So it's a perilunate dislocation, but with a fracture now. So this is the blue line, what you see is called as the greater arc injury, means it's involving the bone. It's also causing fractures. So perilunate dislocation with fractures. And that's when we use the term trans. Trans-scaphoid means the fracture is gone through the scaphoid. So perilunate is around the lunate. Trans is a fracture through the bone, and it could be dorsal or volar. It can also go through capitate, transcapitate, transtriquetrum. Any of these can happen here. Now, the basic principles of management here is appropriate X-rays, which I told you. Sometimes we take traction views like this, and a lot of times these instabilities sometimes can reduce with this. Some fracture fragments you can see, so you might need a CT scan to see where exactly there might be a fracture. And the basic treatment, like any other thing, dislocations would be close reduction, if they cast or close reduction or percutaneous spinning, open reduction, internal fixation. Here ligaments are damaged, so ligament repair. The close reduction is this called as a Tavernier's method, and it's a very, you exaggerate it, this deformity, and then try to push that capitate into back into this lunate fossa here. Difficult a lot of times because patient, even if they come 1 or 2 hours later, a lot of edema sets in, swelling sets in, it's very difficult. But sometimes you might be able to do this. This is one of the cases which we're able to do it and get the close reduction here. But otherwise, most of the times we go for close reduction and percutaneous spinning because they're quite unstable. So pinning is always a good thing. Same process, the radiolunate wires to hold the lunate in the center. Okay, and then the lunate needs to be transfixed from both the sides, scaphoid and scapholunate, lunatotriquetral. This is in perilunate I'm talking of. And then you can put one more wire through this and one more wire here also, almost like a diamond type of a configuration so that it's packed on all the sides. If that doesn't happen, then you have to go for open reduction. So close reduction fails, then you have to go to open reduction. So this is how actually a perilunate looks on the C-arm. So that capitate is behind the lunate here. It's not trying, it's difficult to come back here because of the edema and the ligaments being quite tight there. And that's when you have to do an open reduction. So we start with this flap here, an ulnar based flap here like this, open the joint. So once you open the joint there, okay, what you see first is actually the capitate. Because the lunate is in the front, the capitate is the dorsal dislocation, the capitate is the one, this is not the lunate. So you need to give some traction and then you will start seeing this hidden lunate and the proximal row here. So that is what you need to see. And sometimes you see these chondral damages to the capitate. Very, very important for you to talk to patient. If these are there, patient can develop stiffness and future arthritis. So that has to be documented and the patient has to be told about this. So then you start seeing these ligament injuries and then you have to reduce it. So once under anesthesia, it's difficult. It's easy for you to reduce this. So it goes back nicely there and you can move the wrist nicely. The next important thing is to check for the ligaments. What's happened to the fracture? This is actually a scaphoid fracture this patient had, trans-scaphoid. This is a scapholunate ligament. This is the LT ligament. There is some damage there. The scapholunate almost looks intact. And this is a scaphoid fracture here. So all of these have to be repaired and fixed. And sometimes you go on the volar side also, because there might be the lunate might be some more subluxated. So that is the time you might need double approaches. Otherwise, most of the time we go dorsally first, and then you come back and start repairing each of these ligaments. That is a scaphoid screw going in there in this, and then the ligament needs to be repaired. Whatever remnant is there, we can use suture anchors and other material. And the capsule has to be repaired nicely back. So that gives a stability to the wrist. Again, at the end of the procedure, your wrist should move synchronously nicely. All of them should move nicely. The scaphoid is fixed from the dorsal approach, and the lunate now moves nicely here. So this is how your good fixation ends up with. This is the post-op X-ray of the same patient. Imagine this force continues, and then this very high energy. Patient also has tingling and numbness. You should start thinking why. And then if you take an X-ray, you will see the lunate is now dislocated. So this is from perilunate. Now it has become a lunate dislocation. It's actually a spectrum if you see. So if the energy is very high, initially there's perilunate, then the lunate starts subluxating and it's actually dislocate at the end of the end of the injury itself. So this is what even the Mayfield told long back. So if this force continues and it comes towards the volar side, there are two strong ligaments here, the radiolunate ligaments. They also get damaged. And once that is damaged, the lunate comes out easily. So these two ligaments, the short and the long radiolunate ligaments, are the final, posts holding the entire fort. And once that collapses, the entire lunate collapses out. So that is the lunate dislocation, and that's called as a spilled teacup sign, which is classically described in these situations. Now, patient comes with tingling numbness. That is because the median nerve here is actually compressed by that dislocated lunate here. So the moment you retract that median nerve, you will see that lunate here that needs to be reduced. So from the volar, we start here in lunate dislocation. Then we go dorsally again to check for the ligaments, and that ligaments have to be repaired, and the capsule has to be repaired. The most cases are still frequently missed. That is a sad thing. So I still harp on the point that the normal X-rays, how to interpret, take the proper PA view and lateral view and interpret. That is very, very important. I tell my residents always have the checklist, how the lunate looks, the shape of the lunate, the gillulus arcs, all these things have to be checked. Why it is important is these patients, they end up with chronic wrist dysfunction, degenerative arthritis. Within 5 to 10 years, they end up with degenerative arthritis, especially manual laborers. Delay in treatment influences long-term outcome, but open reduction is still worthwhile, even if patient comes at 8 weeks to, almost 2 months to 3 months. Sometimes it's still worthwhile to go in for an open reduction. But again, depends on how the cartilage status is. So late repairs generally require both dorsal and palmar approaches. Many reconstruction options are available with ligament reconstruction and so many things. But if reduction cannot be accomplished, or if there's significant cartilage damage, you have to talk to the patient, and either you go for a proximal row carpectomy or you have a partial wrist fusion. So these are all salvage procedures, but the basic, the ideal treatment would be open reduction, internal fixation there, if there's a fracture, ligament repair. These are the ones which will give good results. There'll be always some stiffness in these patients. There will be always some loss of grip strength and pinch strength, but still it's worthwhile to give the anatomy back to the patient, especially young patients like this. Otherwise, salvage procedures always give a suboptimal kind of results. Thank you so much for your kind attention.
Thank you, sir, for elaborated talk. So probably we have a lot of questions and also from the audience. So first thing I would like to ask you that what's the role of close reduction, as you told in your talk also. So especially in the presence of scaphoid fracture, could you tell us?
Yeah. As I said, close reduction is not always easy. Patient comes very early to you before the edema sets in. You can check for do a close reduction, but it's not that you stop at close reduction. You always check the stability of the wrist at the end of it. So if you feel that is quite unstable, you can reduce the dislocation in the casualty or trauma, and then put a slab. Make sure you put a good compression so that edema doesn't come. And then after you assess and feel that it is unstable, if you want, you can get a CT done. And then in the theater, you need to fix it at least percutaneously. So that is the role for close reduction. And sometimes the injury is so bad that it's very unstable. And then also you actually get close reduction very easily. But that doesn't mean that you stop at that, put a slab and send the patient. No, it has to be fixed. So that percutaneous fixation should always be the minimum, at least you should do the patient. But there are people who want to feel safe. They can still go for open reduction and ligament repair. So they might tell that that is the ideal. But if there is no fractures and most of them can be reduced nicely and pinned, I think a lot of these injuries heal nicely. Even scaphoid fracture is there. It can be also fixed percutaneously. So at least close reduction and a cast is almost, it's not usually done. So we always go for close reduction and percutaneous fixation at least. That's the minimum you should.
I think message is clear that we should not rely on that.
Yeah,
if you
definitely
have reduced it, then go for open reduction if it is not well reduced, especially in the cases of scaphoid fractures.
One of the greatest advantage of close reduction, if you are successful, is it will reduce the edema for the patient and the pain for the patient. That's very important.
Yeah, Ajit.
Good evening, sir.
Hi, Ajit.
Good evening. So, brilliant talk, sir. Always, I love your talk. The way you speak, it's really amazing. So, I noticed that you have reflected the capsule is ulnar based. What I have learned, it's always the ligament sparing approach of Burgess, which is radial based flap. How it differed than the, because you have raised the ulnar based flap where the ligaments may be injured.
For me, it is where I want to approach, which bones I want to approach. So if the majority of the damage is towards the radial side, and it is still a ligament sparing. If you look at this, I'm still going through the DRC, one cut there, okay, and I'm still going through this. So if you have a plan for capsulodesis and all those things, then yes, what you're telling is right. But if it's just I want to fix the scaphoid and everything, and I need more space there, then I would do a little change there. But the ligaments are not damaged. The cuts are through the same anatomical landmarks, right? It's just at the end of this. So I'm going towards this side. I'm not relying on the end of the triquetrum here. I'm getting more space towards the scaphoid. So that is one of the variations I do sometimes based on how bad the scaphoid fracture is and how I want to fix it.
Yeah, because it will be really very helpful if you are raising the ulnar based flap.
So that's one advantage I found out, at least over my experience, that sometimes this is actually useful. So not rely on the classical ones. Yeah.
Thank you, sir.
Yeah.
Any other questions? So if no, I'll ask one question. I have seen few patients who are having increased scapholunate gap, but there is no functional problems and no pain. So what's your opinion about this subset of patient?
Yeah. Even if you treat them on day one with a good percutaneous fixation, reduce the scapholunate gap and fix them. If you take an X-ray after 3 months, you'll see the gap. I mean, I've never seen a perfectly reduced scapholunate even after 3 months or 6 months, even if it's done very early. And generally, I think we are trying to fix one part of the scapholunate ligament. We are not fixing all the parts of the scapholunate ligament. We don't know which part is injured, how much it is injured, the dorsal, the membranous portion, the volar portion, all these 3 things. So we are not formally repairing. Even if you openly repair, we just repair only the dorsal aspect, assuming that the dorsal part is the strongest one, right? So there is some amount of instability still there, but I think they all heal with fibrous tissue and some scar tissue. That at the end of the day, they might not be really symptomatic. They all will heal because its scapholunate is not just the one portion of it, in the sense that there are so many secondary stabilizers also for scaphoid near the STT joint, for the lunate triquetral, there is a capitolunate. So many things are there. So we should not. There are studies, cadaveric studies, where they've sectioned SL ligament completely, but still nothing major happened. Okay, so what we are trying to do is to give the normal anatomy as much as possible. But we might not be able to do everything, because finally at the end of the day, if you go and do a 360-degree repair, the wrist might become very stiff. So I don't think we should still treat the patient as a patient, not the X-rays. If clinically they are doing good, I think we should not worry about that gap at all.
I think you want to say that if there is no instability, means scaphoid and lunate relation is not changed, we need not to worry.
Yes, definitely you should look at the lunate where it's gone. If it's totally dorsiflexed or something, there is a gap, means yes, you might be facing a problem. But if the lunate is neutral, I think we should not worry about it.
This gap is not important, instability is more important.
Definitely, definitely.
Sir, I have encountered where the capitate is dislocated volarly instead of dorsally. So, what are the tips for taking care of these patients? Because I think they are more unstable injuries.
Yes. I mean, 99% of the time it's dorsal dislocation. There is always this 1% cases which are volar. And as you rightly said, it takes more energy for it to go towards the volar side. The natural tendency is for it to come dorsally. But if the injury is so bad and there is damage on the volar aspect in the capsule also, so if you open them up, you actually will see there is a rent even in the anterior capsule also. And you need to actually have a double approach there, and you have to reduce it back, and then you have to repair that rent there in the capsule. Very, very important. Otherwise, you end up with a lot of instability. So you might reduce it, but then that extra repair is important in this aspect when it's on the volar side.
Okay, you want to show from volar side? No?
Yes, you have to check. You have to at least check how bad is the damage to the capsule, and then for you have to repair that area. You have to retract the nerve, median nerve, and everything, and look at the floor, and then make sure that there is no big rent there. Yeah.
So you want to say that reduce from the dorsal side and then repair from the volar side, or reduce from volar side only?
No. You will get your reduction from the dorsal side. That's not an issue. Yeah. But then you have to check for the volar side also. That's what I'm trying to tell. Because it might lead to late instability. You might reduce it and everything. See, if you really look, there's capitolunate is not there is no true ligament as such. Okay. So if the capitate has to go all the way volar, the capsule has to give away there at the volar capsule. Right. So that is the problem there. Yeah.
So frankly, I have burned my hand with this when capitate was volar, and probably I have not repaired the lunate. Then later on, although he gained the range of movement good, but it was again unstable.
Yeah.
Any other questions?
Sir, if the cartilage of the capitate is damaged, I mean to say extensively damaged, then is there any role of doing a primary mid-carpal fusion? Or we should just reduce it and leave it and wait and see what happens?
I think primary fusion is not a good thing. Even we always give a chance for it to heal. I mean, at least the fibrous tissue comes. The hyaline cartilage won't come back. The fibrous tissue comes, right? So if there's an extensive damage, I mean, really extensive damage, you'll have to obviously take a consent for that, which you can't do on table for the patient, right? Because it's an intra-op finding. So you might have to leave at that. At the most, I can think of an interposition kind of a thing with the capsule. That is one way of coming across, I mean, overcoming that at least temporarily, and later tell the patient that he might require or she might require a fusion there at that point, right? But primary fusion, I think I would definitely avoid. Still give a chance. Fibrous tissue might form, and then you start mobilizing them early, and that fibrous tissue itself will elongate and give them some movements. Yeah, and it becomes really painful for the patient, then we can take a chance, because mid-carpal is the most important joint. All our movements of the wrist start from mid-carpal joint. So once it's fused, I think they lose a lot of movements.
So what is your absolute indication of PRC in a fresh perilunate dislocation?
If a lot of times there is a scaphoid fracture, scaphoid is sitting actually in the forearm somewhere, and it's comminuted, I can't reconstruct it back. That is one thing. Or patient comes late, 2 days, 3 days, 4 days, and we know there's a vascular problem there. Again, there's a major damage to the ligaments. I can't repair any of those things. I think those are the times when we have done a PRC. I mean, especially for me, it's a scaphoid which gives me the decision. And we have seen scaphoid really badly comminuted sometimes. And usually these are open injuries. They're never closed injuries. So there is a chance of infection, so many other things, and delayed presentation. I think those are very few times we have done a PRC.
Sir, I saw a few slides in your presentation that you told that if lunate is volarly dislocated, means your radioscaphoid ligaments are injured. More ligament injuries are there. So, so at this time you are telling that at this time you can do PRC. The balancing ligament for PRC is the short and long radioscaphoid ligaments.
Yeah.
So these seems too contrary to me. So
you're talking of radioscaphocapitate?
Yeah.
Yes.
Yeah, the radioscaphocapitate ligaments. So that's what I'm telling. If these, I mean, the scaphoid is fractured, means, and then it is displaced out completely, we know that the radioscaphocapitate ligament is damaged, right? There could be a volar lunate dislocation. There is a rent in the anterior capsule there, right? But if you want to do it, and then if you can't reconstruct this back, your only option is a PRC. There's no other option of putting all these pieces back together, right? But at the same time, your PRC should be with a lot of soft tissue repair also for it to become stable. So you would have gone volarly. So you should make sure that once you remove the pieces of the scaphoid or whichever, that's why I specifically told that the scaphoid is on the volar side, and your approach will be actually volar side. So that is where when you remove those pieces, you repair all these things. If you can't repair the ligament per se, at least the capsule, whatever tissue is there, should be repaired nicely. And then your capitate will work like your classic PRC. Okay, then only it will work. So it's always that the soft tissue repair should be good in all these things. PRC is not always just taking out those bones and coming out, especially in a perilunate kind of a situation or a lunate kind of. It's not the PRC which we do for the other cases, other kind of degenerative disorders. Here this dislocation is basically soft tissue. So every time when we openly reduce or do any salvage procedures, the soft tissue repairs have to be good, especially in primary setting. That's very, very important.
Okay, I think message is clear that a lot of soft tissue repair is necessary if you are doing PRC in acute settings.
Definitely. Yeah.
Any other question from other faculty? Sir, what's your experience for the old? Because we are getting a lot of late presenting cases.
Yes.
So what's your experience? How late you will go and do open reduction, or you will do any salvage procedure?
Okay. First step is how old is old. So which is basically, for me, old would be at least which will be less than 3 months. Anytime from the time of injury to just less than 3 months. That is for my decision for open reduction bar salvage. So second point is consent for both the things, right? So you take the patient's consent for both the things, tell them that you will try open reduction, you will look at the cartilage, you will look at the ligament, and you'll assess and then take a decision on table. Take consent for both the things. Third, I don't use any external fixator, because when you open, you actually realize your external fixator will never work. Because when you open this, if you see the amount of fibrous tissue, the amount of scar tissue which is happening, and fibroarthrosis between the joint surface, the fibroarthrosis, your external fixator will actually never work. And what we are just distracting them so much that actually it is causing damage to other soft tissues, the ligaments, I mean the tendons and other things. And it's a definite recipe for CRPS later. So that is what we have used a distractor earlier, but over the years we have seen that it's not going to work. So that is the third part. The fourth point is, of course, you open up. Be ready for both approaches, dorsal and volar. But open up dorsally, look at all these things. you use a blunt instrument, especially a McDonald's or any of these bone levers, blunt ones, and start peeling off that fibroarthrosis slowly. And once you start doing that, they start moving slowly. Okay. And then on table, there will be some amount of distraction with your assistant. But then what is important is that debridement of that fibroarthrosis. Once you do that, you'll be able to get the reduction. And then you see how unstable it is. So that the next point is the ligaments, you don't have anything to hold on to most of the times. The ligaments are all contracted. If you try to take a bite through them, they all just come off with your needle, right? The fifth point is the cartilage damage. How cartilage might not be, there might be no damage also in the sense that there's no defect, but the cartilage might not look healthy. The shine is gone and it looks dull, all those things. So once you reduce, you check for the ligament status, you check for the cartilage status. That is where you decide whether you want to just reduce and hold it, or you will go ahead with the PRC or any of the procedures. For that, your radial surface cartilage should be nice. Your capitate should be nice. Otherwise, you plan for interposition with the capsule, what you have lifted. So remember, the most important point over and above is this: when you reflect your capsule, you keep ready for your capsule in such a way that you keep it ready for capsulodesis or interposition. Don't go with the classic Burgess kind of approach there. Okay, so keep your capsule ready for either capsulodesis or for interposition. So if you take these 5 or 6 points before you go, I think a lot of times you'll be able to reduce them, or at the end of the day, you might have to salvage them.
Sir, what is the role of limited arthrodesis in such case of instability cases?
Yes, sir. We can do, if the lunate is nice, the cartilage is nice, and then we can reduce the capital lunate joint nicely, and scaphoid is now gone into non-union and everything. There is an option for that. You can do a capital lunate fusion, scaphoid can be removed, but these are for really late cases when they come. And there's always some amount of arthritis because patient might have a scapholunate instability initially. So a slack wrist which has gone into arthritis kind of a picture. But if there is a dislocation that needs to be reduced, so you're not really worried about capital lunate interface, even if it's damaged, no problem. But your lunate and radius interface should be good for your limited fusion. That's very, very important. Okay. So then it can be done. Yes.
Thank you. Thank you.
2-month-old injury, pure ligamentous Lissa arc injury. How to repair SL ligament? Because sometimes after 2 months, you will not get anything to repair. So is it reconstruction of the SL ligament?
Yes.
How to go about it?
Yeah. Those are the times where you have to be ready both for reconstruction and capsulodesis. So you might have graft harvest to be ready, and also your capsulodesis would help it. So at 2 months, 6 weeks, 2 months, you will still be able to get some remnants which you can stitch up. And with anchors, suture anchors, life has become much more easier compared to earlier times. And if you are lucky, if it's an avulsion from one side, you should be able to get some soft tissues back. And that is the time you add your capsulodesis additionally so that it becomes stable. But if you're unlucky, for the patient also, it's not good, absolutely nothing, you should be ready with your graft for Brunelli's or any of these kind of things. So 2 months to 3 months, I think your consent is very, very important. How you talk to patient, counsel the patient, and what all things to be kept ready in the theater is very, very important. You should think of all possibilities. Your consent should be comprehensive in informed consent of what you want to do for the, because these are a lot of intra-op decisions, a lot of times. So make sure your consent is good. Your armamentarium is ready, suture anchors,
Everything is
for tendon harvest, everything, keep it ready. At the end of the day, you might just suture and come back, if you have a good scapholunate. That's your lucky day. But otherwise, keep everything ready. That's all.
Thank you. Thank you, sir.
Sir, one question that if a old presentation case with good range of movement, would you touch it or not?
It's always difficult to convince the patient that you lose movements. They always have good movements. That's why I showed that C-arm picture. Did you see that Perilunate C-arm picture? How nicely it is moving, right? It moves, but where is it moving? How is it moving is important. And these are the, like if your DRUJ movements also, a lot of times you'll see a wide DRUJ totally disrupted, but they have good pronation supination. It's just that at the end of 5 years or 7 years or 8 years, they develop arthritis. So that is the way as a surgeon, you have to talk to them and sell them the concept that these patients will go for degenerative arthritis very soon. They're not moving at the joint, they're moving somewhere else. It's all a pseudo movement which is happening, right? But if you can convince them and show them what is normal and what is abnormal, even on the x-rays, and tell them that this will, it's up to the patient's choice at the end of the day. After 5 years, he wants to come when the degenerative arthritis happens and he's ready for total wrist fusion, it is up to him. But we have to show them both the things. And I think at least most of the time I've succeeded, and I've also convinced the patient that your movements will reduce, but it's for the good in future, right? Your arthritis will be delayed, and definitely he might do much better. So that is what is catch there. But I will definitely convince as much as possible, and definitely I would like to operate on this patient.
I would like to ask Purnima Patni Madam and Dr. Narendra Saini sir about use of distractor in their practice, because
we have been using distractor from quite a long time. Normally in all patients who are coming more than 1.5 months, up to 3 months, we have been using distractor initially. And what our experience has been that it somewhat makes it easy for the reduction to be attained. The hassle that comes when you are operating on an old patient becomes quite easy. I think Madam would agree with that. Ma'am, you are muted. Huh?
Yeah, there's much less probing and prodding required. The soft tissues have stretched out. And I don't see any harm in it. So there can always be a debate on this.
Yes, ma'am. I think I'll come to Jaipur for that debate, not here. But yeah, as I told you, even we used to use earlier, but over the years, I've seen that even without that, I don't know, we might have to do a comparative study and check, because even without that, intraoperatively, I find it, it takes some time for us to clear the arthrosis there, and it starts moving. What I've seen sometimes where the patient has been referred with the distractor is there's an over distraction. And that is what is not a good thing, because then it leads to stretching of all these tendons and all, and they end up with stiff wrist and CRPS kind of features. So that should not happen. Otherwise, I'm sure with the experience, you know how much to distract, how long to hold it, how slowly you do the distraction. I think you are much experienced with those things, and that is why patients do well. Definitely.
I don't know about well, but we have been doing it. And when you are inserting your blunt lever and if it's very tough and tight, then you might damage the capitate, and these kind of things happen.
Correct.
So, in older cases, his bones also get quite weak.
Yeah.
So, because of the non-use, there is some amount of osteoporosis, and the cartilage can be thinned out. Yes, definitely yes. The risk is always there.
Sometimes just a flake of the cartilage will come off with your lever.
Correct.
But then, of course, you have to do it judiciously. You cannot overstretch the tissues and then hope to get to the...
Yes, ma'am. Yes.
Madam, could you tell what is the judicial limit, means how we should do distraction? What is your protocol?
Amit, we'll have to stop here.
So, because everyone should know, so I'm asking.
I don't know. There's a... Saini, would you like to answer that?
Normally, we normally distract it for a period of, I would say, 1 week or 10 days. That is all. It's about 0.25 mm per day, not more than that. And that too, you have to just see that the capitate is moving. And it is just about at the level of the lunate when you stop and you do an open reduction.
Yeah.
You cannot keep it for long, because many patients I have seen who have been lost in between, and they have come after 3 weeks or 4 weeks, and it is nearly useless to do all this.
I think one way of objectively seeing it also, the radiocarpal space.
Yeah.
Okay. So if your radiocarpal space is twice the amount of the normal space, that's what I taught some time back, then means you're over distracting it. And these are the cases which go for CRPS. So that is how you need to judge that if you really want to look at objectively. The spaces normally is about 2 millimeters all around between the carpal bones. And the radiocarpal is about between 2 to 4 millimeters if the cartilage is young patients is quite thick. And if you look at the opposite side and then you see this and then your gap is increased almost double, means you over distracted it. I think that's how you need to objectively look at it.
Okay. We'll discuss in one case because this about this gap, so we will learn better. Any other question from Ajit or any other faculty? Saini sir?
I've kept a few questions during case discussions.
Ajit will surely have all the bouncers later.
Sir, one just to fill the all discussion, what is your experience about scaphocapitate syndrome? One second thing, I have seen few cases where 4th and 5th metacarpal bases are affected. So what's the reason behind it?
Scaphocapitate is basically again fractures through the scaphoid and the capitate. Now, the problem with capitate fractures, you should be very careful, is sometimes there is a rotation of the capitate fragments. And that should be recognized very early because invariably it goes for non-union. So if the injury is bad and there is a capitate, tilting or displacement, that needs to be recognized early. So scaphocapitate or naviculocapitate syndrome is basically trans-scaphoid, trans-capitate line, fracture line going through this. And the importance of that is capitate again can go for avascular necrosis or non-union based on the displacement of the fragment. So you need to go in, rotate it, put it back, make sure it's fixed nicely. It will heal as long as the raw surfaces are next to each other. But if it's rotated, the cartilage comes like your supracondylar, lateral condyle fractures in elbow. Similar situation happens here also. AVN and non-unions, both can happen here. That is one thing. With regards to your metacarpal base, see, the arc I showed you is one arc. The lesser arc and the greater arc is one way. There are 4 different arcs described actually. It can be reversed. It can start from ulnar styloid and come towards this side. Mechanisms have been described. Trans-lunate arc is described. The force goes through the lunate. The force goes through the radiocarpal joint. Okay. So when there is a reversal of the arc, it can come through the ulnar styloid, it can come through the base of metacarpal, CMC joint, any of these things. There can be an axial kind of force, like your Lisfranc's kind of a thing. So different combinations of mechanisms have been described earlier. And we published one which is trans-lunate, we have described, where we have got the lunate fracture. Arthroscopically, I fixed that there was some rotation, reduced it arthroscopically and fixed the lunate. And then we have repaired the ligaments. So we have published that one. And there is, as I said, even there's one which goes just in the radiocarpal area and it can involve the radial styloid and ulnar styloid. So different mechanisms or different ways the force can propagate have been described. And the reverse arc could be the reason for your metacarpal CMC joint involvement also. But if it is somewhere in the shaft and everything, think of axial force, like your Lisfranc's. It can be radial side, ulnar side, central, all kinds of mechanisms have been described in this.
Okay, then I would like to invite our second speaker, Dr. Ajit Tiwari. He will basically do interactive learning by asking questions so we can learn more.
Is my screen visible?
Yes, Ajit.
Thank you, Amit sir. Thank you all the office bearers of ROSA for giving me this opportunity to present a case in this forum. So I think
Slides, so please do it.
yeah. Yeah, is it visible? My slides are visible?
Yeah, your slides are visible.
Okay, thank you. So we'll move. So here is a 20-year-old young man. He is right-hand dominant and he's basically IT professional. And he was, he was doing tracking. He was going on the mountain, he was doing tracking and he fell. Basically, this patient was from Pune and he fell from there around 10 feet height. And the mechanism was fall on outstretched hand. And he presented to me after 2 weeks of injury. And the wrist was immobilized in the slab, and he presented to me with pain, deformity, restricted movement, but there was no numbness in the fingers. So as sir has told that whenever you suspect a patient, whenever you see a patient which has a huge swelling in the hand, and so always suspect kind of radiocarpal dissociation or radiocarpal injury. And because this patient has fell from 10 feet height, so definitely there must be, it was a high energy injury. So I did the X-ray of the patient. So this is the X-ray. So Saini sir, if you want to do anything, any more investigations, are you happy with this kind of X-ray? Saini sir?
Sir, please unmute yourself.
This X-ray is indicating towards trans-scaphoid perilunate dislocation. To have a view of the cartilage, we can get a CT scan done. Or the bony architecture, if there are any small flakes of bone, we can have a CT scan done for that.
Okay.
Otherwise, I think it's quite clear.
Okay. So my question is that, is it CT scan is always necessary?
No, not always. Not always.
Not always. Okay. Anil sir, what's your opinion? Is it a CT scan is mandatory in all perilunate dislocation, perilunate fracture dislocation, or X-ray is enough?
Well, I go by the same rule as all intra-articular fractures deserve a CT scan. That is my way of looking at it. So whether it's elbow, whether it's anywhere in the body, intra-articular fractures deserve a CT scan just to see those fragments. Especially this patient came 2 weeks later, right?
Yes.
So
yes.
all the more my reason would be to do a CT scan in this patient to see if there are any hidden fragments there which the X-ray is not showing. Very important for that. And also I would be looking at the CMC joints also in this patient. If you look at the second CMC, again, there's some overlap. It could be the X-ray might be looking like that. But still, I would like to see all these areas, and a CT would be a better option for me. Yeah.
Okay. So I did CT scan for this patient, and this is a coronal view. This is SAS, and this is 3D. So if I see that this CT scan shows that it's clear cut perilunate trans-scaphoid perilunate fracture dislocation. So would you like to see any other, you would like to know any more information, or this much information is okay to proceed for treatment?
Any other injuries? He fell from a height of 10 feet. So are
No,
you
sir.
sure that absolutely no other injuries?
Yeah. There's no. I mean that there's no lower injuries or any spine injuries, or there's elbow, shoulder, everything is fine. Just only this kind of thing.
Okay. And you said there's no numbness or anything?
Yeah, he has no numbness, right?
Okay. Yeah. I think
Okay.
they should be okay. Yeah.
So what are the treatment options? Close reduction, percutaneous fixation of scaphoid, or we should go for the open reduction?
I think it's 2 weeks now.
Yes,
and
sir.
I think I would obviously close reduction might not come. So I would definitely counsel the patient for open reduction and ligament repair also, along with that, along with the proper fixation of scaphoid, under vision.
So close reduction of purely ligamentous injury is easier than close reduction of trans-scaphoid perilunate fracture dislocation. I mean that it's easy to relocate the lunate of purely ligamentous injury than the fracture dislocation, where the lunate has a fracture of the proximal, lunate has a pole also, and reduce that part of that lunate is difficult rather than the pure ligamentous lunate. Is it?
So when you have a scaphoid fracture, a lot of times you might not have scapholunate injury, which I showed you also in this one, because the energy dissipates in the scaphoid itself.
Through the fractures.
The scapholunate will be intact. In that sense, a lot of times, you might not get too much of a deformity in terms of the lunate itself. Okay, but all depends on how bad your scaphoid is fractured, is the combination and all those things, and then it becomes quite unstable. The lunate then moves if it is held on with that proximal pole, and there's a lot of combination also. Then it might move excessively. So then it's becoming difficult. Otherwise, as you are suggesting, if it's just a perilunate dislocation, no fracture, it should be easy actually if you look at it, logically, correct? So
Yes,
that's
sir.
how we think. Yeah.
So if we are, suppose we are doing close reduction and this is trans-scaphoid perilunate fracture dislocation, we are doing close reduction, we are able to reduce the lunate and the lunate fossa. Should we go from fixation of the scaphoid should be from the dorsal side or the volar side?
You're talking of open reduction or close reduction?
Close reduction. Close reduction.
Okay. If it is close reduction, then I would prefer my volar percutaneous again based on where the fracture line is. If it is classically at the waist, I would still go volar. But if it is somewhere in the dorsal, proximal pole, I would go for a dorsal kind of fixation. And dorsal percutaneous is not a very easy, thing. So sometimes you might have to do a mini open kind of a thing. But otherwise, if your close reduction is coming very well, lunate is sitting nicely, fracture is at the waist, I would do a percutaneous fixation of scaphoid polarly.
Fair enough, sir. So as you told that I could not reduce this fracture dislocation close. So I planned for the open reduction. So what should be the approach? Is it dorsal versus volar or combined?
Start with dorsal.
So
and then decision.
That's fine, sir. So what is indication of the volar open reduction? What is what is indication of the volar approach? Or combined means that combined approach, dorsal and volar both.
If you see your X-ray, the lunate is not sitting there on the radius nicely. If you go back to the X-ray, the lunate is tilted actually, correct?
Yeah.
See that? So it's almost going towards subluxation of the lunate there.
Yeah.
Right. So this is the time where you have to have a low threshold for dual approaches, first thing. But still, in this case, I would start with dorsal, go volarly. But if that lunate was a little more tilted, I would probably first go volar, push the lunate back, reduce it nicely, because this is not actually classic perilunate. Okay, it's almost going towards the lunate dislocation. So in this case, my threshold would be to actually start volar if I feel that this lunate might not easily come back, especially after 2 weeks.
So purpose of volar approach is repair of volar ligament as well as median nerve decompression?
Yes, that is a primary. But of course, it comes with the added thing that you can reduce it nicely back, easily back.
So, okay. So as there's no median nerve, patient has no numbness, so I think there's no, so there was no need of carpal tunnel release. So my question is that if patient has numbness in the median nerve distributions, should we always go for the carpal tunnel decompression, or after the reduction of the lunate, the numbness will go and it will be fine?
Well, when you are there, you as well release it.
Okay.
Because there's a lot of edema, there's a lot of tissue damage there. So all the better that if you want to sleep happily that day, you just release it and come out.
But sir, if the reduction has been attained dorsally, then also?
No, he's talking about there is a median nerve symptoms and it's dislocated, then and primary would be volar, then definitely I would release the carpal tunnel.
If it is primary volar, then it is.
Yeah.
Okay, so as the patient has no numbness and there's I could have reduced the lunate easily. So I took dorsal approach, that ligament sparing approach of Burgess, and you can see that this is this is dislocated position. This is the capitulum. So this is capitulum. This is radial, the lunate fossa, and lunate is on that side. So I reduced the, you can see that this is ligaments between the scaphoid and lunate was quite intact. So I put 2 wires to reduce the scaphoid fracture to, and then I put the headless compression screw from the whole approach, from the proximal pole. And finally, it's fixed. I stabilize the scaphoid and capitate, and that side from the lunate and triquetrum. And this is after 2 years of the follow-up. So I think he has a reasonable function. Some stiffness is there, but it's yeah, it's united. Fracture has united. Movement is reasonable function. So can we go for other case? Amit sir, or you want to present next case?
So I want to ask 2 questions.
Yeah.
First, as shown in your case, it is sometimes frightening to me also that lunate is slightly facing dorsally. So is it, but in later on X-ray, it looks okay. So what is the interpretation of this thing? Can you slide back?
It's facing volarly in this.
This side, this X-ray you're talking about?
No, previous one. First X-ray. Yeah.
No, after reduction.
Sorry?
After reduction.
After reduction.
It is in this.
No, it's a intra-op picture, sir. This is intra-op II images. So it's not complete stabilization. I have fixed the scaphoid, and after that, I have to put the Vyas through the scaphoid and capitate. So I think this is the final fixation.
No. And here you can see there looks the lunocapitate lunotriquetral dissociation type of thing. Is it means it is due to view or it has some significance?
Probably it's not a correct view, because though classical teaching is that always make a diamond shape, you stabilize the lunate with the triquetrum also. So, but if you see that this final X-ray, this I think triquetrum looks fine. Yeah.
So sometimes these things are frightening once you have reduced the things.
Yeah, but sir, your comment, please.
But sir,
no, I think it's just probably the view. I think it's not absolutely. It's fine, because my basic thing would be to screen and check. That's all. That is the proof of how everything is moving. So before you leave the theater, always screen in all directions and check. And if they all look fine, I think we should be happy with that. Yeah.
And second question to all faculty, have you any experience about ulnar nerve symptoms after this Perilunate and Lunate dislocations?
After Lunate, we have a publication coming up for that. The Lunate was actually displaced towards the ulnar side, and obviously it was pressing on the ulnar nerve. Otherwise, routinely no, unless the Lunate has dislocated and it's gone towards the ulnar side. And there was also a ligament capsular injury there. So not ligament, it's capsular injury in this patient. And the ligament could actually, the Lunate could actually escape and come all the way towards the ulnar side. And this patient actually came with ulnar nerve symptoms. So one case we saw a couple of months back, but otherwise routinely no.
And how to document these injury for publication? But clinically we can see, but because nothing will be positive in acute setting.
I mean, you're talking of
investigations.
No, Perilunate with ulnar nerve symptoms. And what is the reason for that?
No, because I have also seen one case where ulnar nerve symptoms were there.
Okay. But I think in our practice, we get an ultrasound done to see if there's any contusion or edema of the nerve or any of those things. I mean, we don't rely on NCV, but definitely an ultrasound is worthwhile, I think, at that point of time.
Yes.
So, sir, if I'm not wrong, then the last limit of, the upper limit of upper limit of open reduction on stabilization of the perilunate dislocation is 3 months, right? After 3 months, we should consider as for the salvage procedures.
Yes. Operated good results. Third, beyond that, whenever we have gone in, we have always ended up. Am I audible?
It was not clear, sir. Can you repeat, please? Thank you. Please.
No, whenever we have gone beyond 3 months, we have always ended up in salvage. We have not been able to do a good job there, so we have chosen to do a salvage at that time. I think the latest was probably, I think, around 2.5 months, plus or minus 1 week. After that, it's always been a bad experience.
One publication from PGI Chandigarh, they have divided 45 days criteria.
45 cases?
45 days criteria.
45 days.
6
okay.
weeks.
Okay.
We consider means reduction after 45 days salvage procedure.
As madam was telling very nicely, it all depends on your, how you handle the tissues there when you go in late, how bad the cartilage is. Every patient is different. So you know the bone quality, the cartilage, the ligaments, each of these, when you start debriding them, loosening them up, it all depends on that. So it goes case by case, I feel. That is what I feel. We can't generalize these patients, especially late presentations.
Is after 3 months, definitely.
Yeah, I think majority would fall into, majority would fall into a bad category after 3 months. So the gray zone is between the 2nd to 3rd month most of the time. It can go either way, but generally up to 2 months you will be able to do a nice job of reduction.
Okay. Ajit, are you presenting second case?
Yeah, definitely. So, okay. So this is, again, 35-year-old gentleman. He's a farmer, basically. He had road traffic accident and he fell on out his chest hand. Presented to me after 1 month of injury. There's restricted movement. There's just jog off movement over the wrist joint. There's a deformity and patient has numbness in the index and middle finger. So I missed the X-ray. And because this was the X-ray, the primary treating surgeon has missed this injury, and that's why he presented to me late. So this is the CT scan of the patient.
The scaphoid is intact?
Yeah.
Yeah.
The scaphoid is intact, sir.
Yeah.
It's pure ligamentous injury.
Pure ligamentous. So probably here would be a primary volar approach, as you were asking.
Okay.
With that numbness and everything which patient is telling, and where the lunate is tilted, almost become vertical now.
Yeah.
Yeah. I think
so the only volar approach or the dorsal approach too?
No, you have to finish the volar side,
And
decompose the carpal tunnel, and then go back to the dorsal side. Yeah.
Okay. So I opened on the dorsal side first, and this was the lunate was dislocated. This is capitulum, and this is after reduction. But after reduction, what I found that lunate was quite unstable. It was not sitting. It was very unstable. So what I did that if you can see that. Yeah, this is this is scaphoid lunate. Means that this lunate was unstable in both the scaphoid lunate and lunotricutal ligament was injured. So it was completely unstable. So lunate was not sitting properly. It was, that it was dislocating repeatedly after reduction. So what I did that I first passed the wire from the radius to lunate to stabilize the lunate in the correct position. Then I repaired the scapholunate ligament. Anchor was not there. I made a small hole in the lunate and repaired the. This is after repair and stabilization. This is then I repaired the capsule, and finally I repaired the this extensor retinaculum on the dorsal side. I had not gone on the volar side. I just did everything on the dorsal side, and this is the final construct after the repair, everything after the repair and the stabilization with the lunate with the scaphoid and the trachea.
Any reason why you didn't start on the volar side? I mean, were you sure that you will get it from the dorsal side?
Yes, sir. Actually, I opened from the dorsal side first, and I was able to reduce it. I put the the laminar spreader on the from dorsal side, and it's just little bit soft, and lunate came at the place.
Okay. I mean, and the patient's symptoms were
symptoms has gone. It was 1 month-old injury.
Okay.
So is it right procedure or any kind of PRC would have been considered for this patient?
I mean, absolutely no PRC if you're able to repair the ligaments and if cartilage is good and you're able to get the reduction. I think you should be sticking to what you've done. My only thing would be that for me would be still, because patient came late and then there is some carpal tunnel symptoms, I would probably release the carpal tunnel and then come back to the dorsal side and repair any volar deficiency there.
Okay. Okay. Sir.
I mean, you were able to repair the ligaments because you had the remnants and everything.
Yes,
but the lunate would have been still unstable if this was not there, and also there was the volar rent would have been healed by fibrous tissue by now, but still it's an unstable kind of a situation. So in that way, maybe as a surgeon, I would feel safe to release a carpal tunnel and
repair on the volar.
Yeah, the space of Fourier and everything to repair and then come back to the dorsal side. Yeah.
So this patient's outcome is not still with me because it's last month I have operated. Probably let's see that how it goes. I don't know that how it will proceed, but let's see how it goes.
Ajit, at what time did the median nerve symptoms resolve after the surgery?
So I think next day he was fine. He was absolutely fine.
Immediately. Oh,
Yeah. After next day when I visit for the round, I asked him that. He told that now I'm feeling numbness is not there. I mean the pain is not there. Probably numb.
Okay. Again, the DRUJ is unstable. I mean, in TROP, was it stable?
Yeah, DRUJ was stable, sir. DRUJ was stable.
The X-ray.
Yeah, sure. I don't have that final X-ray. This is II images.
Okay.
So okay, this much. Thank you, sir.
Thanks, Ajit.
Thank you, sir. Thank you. Then I'll stop sharing, sir. Amit, sir. Amit, sir. Unmute yourself. Amit, sir, please unmute yourself.
Okay, sorry. So I'm presenting a case and we'll discuss the things. Are you able to see my screen?
Yeah.
So this 20 years old right-handed male who is a student, and he was quite interested to do some Air Force training where he has to rope with the he has to get the mount where there is a hard training where he has to use wrist. Unfortunately, he fall down from the two-wheeler and he had pain swelling in his right wrist, for which X-ray was done at local hospital. So I'm directly coming to the X-ray. Narendra Saini sir, could you read X-ray for me?
Yeah, the lines of gullilas are broken. There is a gap between the scaphoid and the lunate. You can see there is a fracture of the radial styloid also. Scaphoid probably looks to be intact here. So the brunt of the injury has been from the trans-styloid type of a dislocation, perilunate dislocation.
Chaturvedi sir, you want to add something? Sir, unmute yourself, please.
Unmute.
I think on X-ray also, the picture is quite clear. There is increased space between scaphoid and lunate and fracture of radial styloid. Even to see some obscure fractures, if CT scan is done, I think it will be better.
Any other comment from anyone, or shall I proceed?
You should also look at the articular surface of the radius also. It's almost like the scaphoid is pushing it, causing a styloid process fracture there. There might be a dipunch element there. That is one thing. And if you look at the capitohamate junction there, that space is also increased there. The metacarpal is not sitting nicely there, the base of the metacarpal. I'm not sure, it could be the view at least, but because sometimes you see these axial injuries, so we have to be careful with this, whether the force is passing through that junction there and coming to between the scaphoid and the lunate down. So that will be the one of the way the force passes And so you see that small gap between the third and the fourth metacarpal and the capitohamate A junction. And then that force comes down to the scapholunate junction here. And the scaphoid is pushed away. It takes off a part of the styloid and it can cause a dye punch element there. So that's one way to describe it. Otherwise, it could be just a transstyloid kind of a perilunate dislocation, as Saini sir said. And it will go through the styloid, it will damage the scapholunate, and then it exists. So both ways you have to think.
So means there should be CT scan to rule out the further.
Yes, yes.
Okay, just a hypothetical situation that there was nothing in the fourth and fifth metacarpal and hamate, then,
Okay.
sir, how you will proceed? What will be?
Yeah. So either you do a CT or you can take a traction view and see how things are falling back and see how it can be reduced. Definitely, scapholunate is completely injured there, which requires a formal repair. Styloid requires fixation. The scaphoid has to come back and sit nicely into the scaphoid facet of the radius. And then you'll have to reduce this. The capitate you see is the dorsal aspect to the lunate. So I would primarily check under C-arm, see what is happening with the traction and a close reduction, and then take a decision to open it.
So, anyone want to add up anything or comment? Ajit, what approach would you use for this?
I think dorsal approach would be fine.
Dorsal approach.
It should go from the dorsal side.
But sir, any technical tips to reduce styloid thing? Because you need to see both aspects. Is it okay to reduce with the whole dorsal approach, or how to deal it?
I mean, don't underestimate that fragment, because one, it has attachments of radioscaphoid, starting of the radioscaphoid capitate itself. It also had attachments of brachioradialis. So it's not an easy fracture just to pin it down. So you need to make sure that you visualize it, and then it's not as small as it looks also. It will be quite a big chunk also. So even if you go dorsally, your incision should be planned such a way that you might get a view of that, and under vision you'll have to pin it back. Or sometimes you can use a headless screw also for that matter. But make sure that it's come back nicely, because it has a lot of attachments, soft tissue attachments.
So I think you will prefer to take ulnar based flap in this condition because you want more exposure on radial side.
I might change so many things, right from the skin incision to, the capsular incision based on where I want. So everything is happening on the radial corner, as you can see, right? So in that sense, you need to customize a little there. Yeah.
So, but unfortunately, this patient was managed somewhere else. And I think the treating surgeon was more focused on this styloid piece, and he did this. I think the message with this, that this X-ray is not clear, and but you can see the empty lunate, and after a month he was advised to do physiotherapy to get movement, but he presented to me at 2.5 months when his range of movement hasn't improved after vigorous physiotherapy.
Was any surgery done in between?
He did open reduction or from the radial side and try to fix radial stellate with headless screw.
So that is I think classical underestimation of that fragment.
Yeah.
Your headless screw will never work if you miss the main fragment itself. It's just there. It's not doing, even if it probably held in the beginning, it's just given off later because the soft tissue is not addressed there, right? And that the soft tissue is always stronger than the bone. Remember that in any place for that matter. So they will always deform the whole situation very soon. As if if the brachioradial is pulling on that and everything, no implant can stay there if your soft tissues are not dealt with. That's the message I think we should give them.
Secondly, without reducing the scaphoid, this won't come either.
Definitely not. Yeah.
So, as Sir has talked in his that how not to miss, so we'll not discuss again because the aim of today's theme is how not to miss these things. So now my question to Dr. Anil Bhatt, sir, at 2.5 months, what will be your management in this condition?
Okay. Basically, go with an open mind to see what is possible and whether, if at all, that scapholunate can be reconstructed as long as the cartilage and everything is intact. So one is the reducibility and second is the reconstructability. So both ways we need to take a decision so tell the patient that, again, what I told earlier, either repair, reconstruct, bar, salvage. So in that mindset, if you go, I think it'll be much easier. That screw has to come out, and then you need a wider dissection to make sure that all those soft tissues are, that radial styloid, that scaphoid has to be reconstructed nicely. If your scaphoid and lunate are going to be reconstructed. Otherwise, you might, if you're going for a PRC kind of a thing, then it's okay. But still, that will give pain for the patient all the time. So that screw has to come out. And if you are able to reconstruct the scapholunate ligament because the cartilage is intact with either Brunelli's or any of those things, then it's fine. If not, if you have a threshold, I mean, there is a cartilage damage and absolutely no way you can reduce this back, I think hopefully the radial surface is fine, then I would go for a PRC in this patient.
So the radial surface will be the determining criteria, no? Scaphoid fossa.
Correct.
Anyone want to add? Chaturvedi sir, Ajeet or Saini sir, if madam is there.
Absolutely agree with Bhatt sir. I think it's a very difficult situation that you have to decide on table that what's there and how to proceed. Because if you'll see that the lunate is sitting in between the scaphoid and lunate, this capitate is sitting in between the scaphoid and lunate. So wide gap is there. There will be nothing to repair there. So I don't know. It will be very difficult, tricky situation.
I also feel that so much of time is elapsed after injury, 2.5 months, and there might be fibrosis. It's very difficult to reduce joints, and PRC will be the best option, I think.
Saini ji, how you will proceed?
I think I will agree with Bhatt sir, but one thing I want to make a point here: if you can reduce it, then probably a ligament reconstruction should be attempted. But if you can't reduce it, then PRC is an option.
Do you want any pre-operative destruction in this case?
Yeah, normally you can do.
Yeah, so as we have common thinking, so I did pre-operative destruction. Initially I was using this method. So pre-op distraction for 10 to 15 days, and then it make easy. But sir, can you tell objectively how to measure that gap? Means I think you were telling about
Yes.
Radiolunate gap.
You see that Radiolunate gap now, right?
Yes.
And then you see the next level between the mid carpal. Then you see the CMC level. All three areas, all three levels you see. And at every point, if your gap is much more than the normal, less than, usual 2 millimeters, so you've already started over distracting it, right? Now, second thing, why I might not, it might have reduced a little here, but if you see again, you're relying on the tendons, you're relying on capsule, you're relying on ligaments for your ligamentotaxis, right? So here you can't rely on capsule, you can't rely on the radioscaphocapitate or any of these ligaments because they're all damaged. So you're basically relying now on your tendons, extensor and flexor tendons to get it back, to some degree of reduction, right? And so that is where my objection comes in terms of not using it. And definitely, if you see the Radiolunate gap is much more than the norm. Correct?
Yeah, Radiolunate is increased.
Yeah. And your lever arm is quite, away from where you want to do it. If you see your proximal pins, correct? So I don't know whether it will really work on the wrist joint. Saini sir is more experienced for these fixators. So your pin placement also is important. How far the lever arm is from the joint for your distractor to work is also very important.
Saini sir, would you like to comment on placement of pins and all?
Pins normally are placed at the base of the metacarpals, just at the base of the metacarpals. I think they are appropriately placed here. And since the injury is not extending in the distal joint, the carpometacarpal joints, then probably the distraction will be at the midcarpal level.
So, Saini sir, you always put a distractor on the both side, or is it radial side?
No, it's always bilateral.
Always on both sides.
Yeah.
And the proximal pins, is it based on the length of the fixator, like generally whatever is available, or would you try to shorten that working space of the fixator?
Normally, it is mid arm level.
Mid forearm.
Yeah, mid forearm level, sir.
Okay.
So, because he wanted to go Navy and he was required a stable wrist. So, but as it was too late, so I did the initial distraction for the open reduction. But when I opened from the dorsal approach, I found that the scaphoid fossa was not good. So then on table I changed my plan, as I had explained to the patient that we may landed up in this. So I removed the loose headless screw. It came easily, and then did the proximal carpectomy. In the initial days, I used to stabilize the proximal carpectomy with a pin for 3 weeks. Nowadays, I'm not doing this. So, any comment up to this time? Anyone wants to do?
No, that's why I said initially the scaphoid, it could be a tie punch injury. So you should be thinking about the cartilage damage there always. It's not just a radial styloid fracture there. It's a scaphoid which will push the radial styloid and it will come out. So it's always that cartilage will always be damaged there, and it's like a tie punch kind of injury. So that's what you need to expect. And I think what you've done is fine. and hopefully a patient would get good, at least reasonable range of motion.
So as there was cartilage damage, have you done any kind of interposition in between the capitate and distal radius?
I think the lunate space would be good, right?
Good,
Was
yeah.
it?
Lunate fossa was good. Only
Okay.
the scaphoid fossa was not good. So, when I removed the pin, it was like this. And now it is almost, I saw it is 10 years. This X-ray may be 5 to 6 year old post injury. It was done in 2013. So now you can see there is separate how this scaphoid fossa is appearing.
What are his symptoms now?
Now, he has reasonable good range of movement. Dorsiflexion is only last 20 degrees restricted, but palmar flexion is restricted.
Okay.
And he's having good ulnar deviation and radial deviation. And he has changed his career, and now he is trying for some teacher job. And, but he didn't have any pain. He's having good range of movement at the wrist. So, and he has good power in his hand. So, any comment to this?
No, good. He's become a teacher now. Only online classes. He won't have much problems. He's young, so he will definitely develop arthritis eventually. That is what you need to tell him, and look after his wrist nicely so that he doesn't carry heavy weights, doesn't do many major things, because eventually that will act like a pincer, the capitate and the lunate, and he will start developing. Scaphoid fossa is already damaged. Even there's no articulation there, probably a lot of fibrous tissue. That's why he doesn't have pain. But the capital lunate over time will start wearing out. So as long as he looks after his wrist, then I think it should be okay. Yeah.
Yeah, as he is from farmer background, and but he's not doing that job, agriculture job. So I explained him that use this wrist with judicious range of movement and force. But now it is 10 years. He's continuously in follow-up with me.
It'll be very interesting to see after 10 years.
Yeah.
Yeah.
Good, but at least you have given 10 years, good 10 years to him. He's using his wrist. Otherwise, he could have not used.
Always we take credit to us.
But sir, I have seen a few patients of neglected trans-scaphoid pellular dislocation who have been performing quite well for years without doing anything.
That's what I said. I mean, it all depends on how they're using it and for what they're using. I mean, you see so many scaphoid non-unions. They have full movements, absolutely. They come for some other thing, we take an X-ray, you see a scaphoid non-union.
Yeah.
We all know the natural history, but it all depends on how they're using the wrist also.
Yes.
I mean, their activities, their weights, sports, so many things. So we can't generalize these, telling that they might do well for a long time. It all depends on, it's like the hip joint. So it all depends on how they will use it and how much of wear and tear happens. But yeah, eventually the body will obviously, try to repair things as much as possible. And inferior quality tissue might come, especially in hyaline versus fibrous. But that would be good enough for most of their activities. So we should not take that as the truth for all the patients. The truth will be always a degenerative arthritis when there is a cartilage damage. That is the natural process. How much of compensation somebody can do and how much sparingly they can use is the question. That's all.
Sir, at this point, I want to ask one question that snack risk means scaphoid non-union advanced collapse. I have seen few patients in 8 to 10 years they develop arthritis. So, what is limit for these perilunate dislocations?
I didn't get you the last part.
Like this perilunate injury, any time duration is there where they start showing degenerative changes?
So you have the capitate staying out, if at all it's not reduced, right? You have the radiolunate staying intact, correct? So I'm talking of classic perilunate, which has not been reduced and patient comes to you after 10 years or whatever. So you see the difference between snack and now this one, right? So you have a capitate which is staying out and the cartilage is probably worn out, but the radiolunate is intact. Okay, and the movements where the midcarpal is supposed to happen, there's a pseudo movement happening now between the capitate dorsally and the lunate in the front. Okay, so that is where the movement is happening. So in that sense, it's totally different from to compare it with the classic snack wrist or any of those things. So the pseudo movement, as Saini was telling, will look nice initially, and as long as the radiolunate is okay, they don't have pain also. But eventually, what happens is there will be an arthritic thing happening with the capitate, with the lunate surface, and because of the wear and tear of the radiolunate, that will go for arthritis. That is what happens, and so the time period might be probably a little more longer compared to a classic snack wrist or a slack wrist.
So I think we are finished on time, and I'm highly thankful to guest faculty and ROSA office bearer and ISSH office bearer to give me opportunity. And I would invite Dr. Rahul Katta sir to conclude the session and
Thank you so much, Amit, and thank you all the guest faculty members, Dr. Anil Bhatt and Dr. Ajeet, and especially the vast experience and the expertise of Dr. Anil Bhatt, how he has enlightened us regarding the perilunate dislocations is fantastic. I think we have learned a lot today. So thank you so much. I would like to also thank our state faculty members, the Jaipur Hand Surgery Society members, and the other panelists for the active discussions in today's webinar. We are also thankful to the OrthoTV people providing us a platform for presenting the good academic work from Rajasthan and the master classes from the guest faculties. So thank you so much. We'll meet again next month, again with some new topic in master class. Good night. Stay safe. Bye-bye.
thank you all.
Thank you, sir. Thank you so much.
Thank you. Thank you so much, sir. Thank you.
Ajit.
Good night.
Thank you, sir.
Sir.
Good night, sir. Good night.
Madam, please give my
Dinner
regards.
is waiting. ISKCON में डिनर करेंगे आपसे.
Yes.
Okay, thank you.
Okay.
Bye.
Thank you.
Thanks, Ashok, if you're still there.